looking at periodontal management, impacted canines, orthognathic surgery, also this year's 2021 Northcroft lecture delivered by Professor Johnathan Sandler. So I'll meet you guys at the end to give you my reflections upon today's conference. As a reminder, the podcast is an opinion piece and may not be 100% accurate or representative, although we try our best to make sure that it is. The podcast is not endorsed by an institute or by the speaker and is the independent work of myself, Farouk, and the Orthodontic and Summary team. This lecture is entitled Paeds and Trauma, What I'd Wish I'd Known by Susan Kindelan and Claire Rooney. Susan is a pediatric consultant in dentistry and Claire is an orthodontic consultant. I really like this lecture because both lecturers described about their experiences in managing pediatric cases with orthodontics. They spoke a bit about the evidence, but also very honest about it, as well as including the patient's expectations in that journey as well. So it gave a really nice overview of this as a topic. They started off by describing the prevalence of trauma, which is around 12% for 12-year-olds. We know that our orthodontic patients, as they come in, around about 1 in 10 have had trauma or will have trauma during their treatment in orthodontics. From our perspective, well, where does the evidence lie in managing these clinical cases? Well, they were really honest and stated actually the evidence is particularly weak due to the nature of having trauma not being a controlled event. However, fortunately, this information has now been gathered and is accessible through a resource, more precisely a website. The International Association of Dental Traumology has put this information in an intuitive website. We can see how to manage the trauma immediate and long-term management, but also the prognosis to advise our patients. Last year, in the Journal of Orthodontics, there was a publication on the guidelines of orthodontic management for traumatized teeth. This was written by Cara Sandler and their group in Yorkshire in 2020. So how do we manage traumatized teeth? Well, we're looking at minor injuries to begin with. Concussion or subluxation. Generally, we're looking at patients who have had gingival fibres which have been torn and some level of bleeding at the gingival level. For these patients, a 3-month wait prior to orthodontic forces is usually sufficient. Moderate cases, looking at intrusion injuries and lateral luxation. So if intrusion, there's been significant damage to the vessels of the tooth. If the tooth is immature, really we want to let this tooth spontaneously erupt, less likely for root resorption, and that's something that they mentioned has changed over the years. If it's a mature tooth, we still really want to prioritize spontaneous eruption. If it's beyond 7 millimeters, looking at surgical repositioning of this tooth. Now, what was new to me is that they described this tooth is going to have a damaged blood supply. We are not going to maintain vitality. After we've surgically repositioned the tooth, it needs to be root canal treated 2 to 3 weeks later. Lateral luxation is usually where we have displacement of the tooth, and also there's a bony fracture usually associated with it. We reposition the tooth, put a light arch wire in, and maintain the tooth for 6 to 9 months before going on with our orthodontic treatment, allowing bony healing to succeed. They spoke about significant severe tooth injuries, the crown root fractures and the root fractures, and these are teeth which generally have a poorer prognosis as time goes on. Now, what I liked about this bit of the lecture is they described a poor scenario. However, they still described managing it with the patient's aesthetics in mind. The tooth is avulsed, it's of very poor prognosis, but still reimplanting it so the patient can have some aesthetic benefit from it, and then planning the short-term, medium and long-term management of that case. They described the rest periods when patients have trauma. Minor, moderate and severe injuries. Minor being 3 months of rest between orthodontic forces, moderate 6 to 12 months, severe injuries looking at 12 months onwards. They describe the challenges in managing these patients. We know from the evidence if they've had root canal treatments to a tooth, there shouldn't be any significant risk of further root resorption. However, their initial traumatic injury may still result in that process occurring. When it comes to canal obliteration, so every traumatic case, there's a chance of 4 to 24% that they will have canal obliteration. Now, it's actually a sign the tooth is still vital, and this can occur up to a year after the injury. However, and what was new to me from this lecture was that they carry an increased risk of loss of vitality during orthodontic treatment specifically. So when we're seeing patients with canal obliteration, we need to warn them orthodontics can result in loss of vitality and therefore require root canal treatment. What happens if a patient turns up really late when it comes to the presentation? Well, the first thing they mentioned was it could be a safeguarding issue. Why has a patient with a significant injury presented so late? If the apex is still open of the permanent tooth, they no longer favour apexification. So this casts me back to when I was in dental school, the use of calcium hydroxide to try and achieve a barrier at the end of the canal. They now look towards using root end closure, using materials such as MTA to establish that hard barrier more predictably. Also, there is now the advent of regenerative endodontics. Again, this was new to me. This is the premise of biologically increasing the root length and wall thickness, involving a variety of steps, but essentially involves creating blood at the end of the canal and allowing the growth to still continue. What they mentioned was that actually this is still relatively new and unpredictable. So unless there's half of the root or less left, they'd rather go for root closure using MTA. Now, what happens when a tooth is of really bad prognosis? What can be done long-term wise? Well, there's the premise that if it's ankylosed, we still want to maintain the bone, but we know the tooth is aesthetically going to be unattractive. How can we square this circle? This is the idea of decoronation, removing the crown of the tooth and going subgingival, but maintaining the root in place. The idea here is that the alveolar bone defect doesn't develop as the rest of the dental alveolus erupts with this patient, and it prevents a vertical bony defect when it comes round to having an implant later on. They describe autotransplantation, how this is a really advantageous process. It doesn't involve any prosthesis taking place. However, they were honest. It requires a lot of clinical commitment as well as restorative commitment. Now, I think when we hear about autotransplantation, it's usually shown to be the ideal scenario for any patient. However, it does come with these other factors, and I'm really pleased that the speakers describe them. It isn't. The next lecture is entitled, Are We Heading into a Recession? This was a lecture by specialist periodontist Ian Dunn, looking at the periodontal considerations in orthodontic management. So Ian started off by relatively scaring the audience and describing litigation, and the most common cause of litigation in dentistry today is that of the periodontium, and payouts exceed £200,000. He defined now we do have a way to work out what is stable, what is not stable, and it's really quite clear. We look at a site level, we look at a patient level, and he broke it down. So a patient who has got a site level, which is stable, i.e. we're looking at one tooth, we're looking at a closed pocket, that is a probing depth of 4 millimeters or less, and no bleeding on probing. He also described the patient level assessment. So overall, bleeding on probing being 10% or less, and periodontal probing depths being 4 millimeters or less, or having no bleeding on probing and a 4 millimeter depth. So those are the three markers that we're looking out for to find that periodontally stable patient. He then also described the unstable patient as a point of comparison, periodontal probing depths greater than 5 millimeters or 4 millimeters and bleeding on probing. He also mentioned how periodontal assessment is not 100% science. Patients who have no bleeding on probing, 30% of them do go on to develop some form of periodontal disease. So we've also got to take other markers into account. He gave a general rule when it comes to orthodontic treatment. Patients should have periodontal stability, but it should be sustained stability. And in his mind, that's 3 to 6 months of maintaining this level of oral hygiene. He talks about treatment during orthodontic care and supportive care every 6 to 8 weeks, so increasing the frequency of their interactions with a hygienist, for example, has a dramatic output to their hygiene during their treatment and their long-term gingival periodontal health. He then went on to speak about gingival recession and how we have controversy over this topic. He spoke about possible etiologies, whether it's toothbrushing, smoking, inflammation, and he also spoke about the anatomy of the actual bone itself. In his empirical experience, he's noticed natural dehiscences occurring around upper canines, occurring around anterior teeth where there's crowding present, and also in expansion cases. Ian was very clear to say this is his experience and wasn't supporting it with any evidence besides that. Now for me at this point in the lecture, it now starts to muddy the water. If we have a case where we are doing some expansion or some orthodontic treatment, actually, could it be that there was a periodontal defect there from the outset and it just emerged during orthodontic treatment? Back to the lecture. So Ian then spoke about the different phenotypes of the gingiva, dividing it into thin phenotypes and thick phenotypes. The thin phenotypes, the ones we're all worried about, whether it's restorative dentists or orthodontists. High scalloped lines, thin interdental papillae, narrow zone of keratinized tissue. Essentially, we look at them, and if you put a probe into the sulcular gingiva, we could see it shining through. The thick periodontal phenotypes. Essentially, cases we can do whatever we want, and the periodontum won't really change. Low scalloped, thick interdental papillae, and thick band of keratinized tissue. What was interesting was to hear what Ian thought were indications for intervention. He actually described aesthetics as being the main indicator for recession defects, as they're usually self-limiting when they do arise. So aesthetics drives the management. He also spoke about certain cases where recession is getting worse but there's good oral hygiene, or if it's unstable due to access for cleaning. He mentioned it's not a treatment for patient sensitivity. That is not what a gingival graft was going to do. He then concluded by describing retention, some cases he's seen long-term wise with bonded retainers, specifically twist flex materials. He described how they can cause adverse tooth changes. And this was resonant of Simon Littlewood's lecture looking at retention, and how we do get this third movement taking place. It's not relapse, it's in another direction. And he recommended keeping an eye on patients with bonded retainers, and if we detect some movements, replacing it, because there's some activation now taking place with that retainer. This lecture is entitled Canines, What I Wished I'd Known by John Scholey. So John gave a walkthrough of his experiences managing impacted canines, how he's changed his practices, and also what his concerns are going forwards. John started off by describing the mechanics he used to align a canine. He uses piggyback mechanics, using a base stainless steel wire and nickel titanium as the active wire. And he spoke of modifications to this, which I haven't come across before, introducing a open coil or push coil on one side of the active nickel titanium wire, allowing direction to take place as the piggyback mechanics are working. He mentioned the use of TMA auxiliary arch wires to extrude a canine, using slingshot mechanics if the canine is in crossbite. That's an attachment palatally, and using elastomeric chain. He also spoke of his use of temporary anchorage devices. And what was interesting, he said he was really keen on this and now only uses it in specific situations. Sounds like someone who's had lots of experience with it has now come to where it works and where it doesn't work. And he gave two scenarios of its use. If there's a buccal canine present, which is impacted, and very close to the lateral incisor. So he positions the tab between the upper first permanent molar and the upper second premolar and applies a distal force to that canine, taking it away from that lateral incisor. The second is incorporating it in with a TPA and allowing it to then apply the palatal traction to a canine. One of his favourite methods of allowing a canine to erupt is using a blister spring, using an 014 stainless steel wire bent with a loop activated in an occlusal direction in order to extrude the canine. He also spoke about other tips that he's learnt along the way. When a canine is close to coming through, try to resist the temptation of bonding a bracket. Usually the soft tissues are bunched up around this canine. Leaving it for 1 to 2 visits allows the gingiva to remodel, allows some passive eruption to take place as well, specifically for our younger patients, and therefore reduces the anchorage demands, reduces the messiness around putting on a bracket to these teeth. He spoke about interceptive treatment and how he has gone to and from this as a concept. He spoke about extractions of primary canines are a reasonable idea, but not suited to every case. We have the Cochrane Review by Nicola Parkin, which shows that actually it does work well, however, it's for a certain patient population, younger patients. We also need to create space and review these patients to see if it does come through. Nothing is 100%. He spoke about risks versus benefits. Sometimes the hero orthodontist comes out inside of us and we wish to align everything. However, he spoke about the pragmatism of this. If the patient has a low gingival margin we need to extract, let's extract the most displaced tooth, i.e. the impacted canine. If there's a 4-2 contact, let's remove the most displaced tooth. He concluded with his concerns of managing impacted canines, and it related to the age and stage of referral of impacted canines by general dental practitioners. Now, he spoke about how he's trying to manage this within his region, but what he found was that 50% of canines were being referred late after the age of 14. And he carried out some studies in his region, and he showed that actually when patients were referred less than the age of 14, or 14 itself, the canines were usually in a better position. When they were referred after the age of 14, usually the position was poorer. And he mentioned how this does potentially have an impact on the long-term prognosis of the patient's teeth and the management of their orthodontic care. This lecture is entitled Orthognathic Surgery, What I Wish I'd Known by Lucy Davenport-Jones. Lucy looked at 3 aspects of orthognathic surgery, that of 3D planning, body dysmorphia, and obstructive sleep apnea. She started off by describing the digital workflow, involving the use of a cone beam CT, scan models of the dentition, utilizing that information to create digital surgical planning, having customized plates formed, and then allowing a really accurate analysis of what was planned for the surgery and what was then delivered to allow the learning process to then take place. One of the things I picked up on in Lucy's talk was about a video assessment which she does for all patients. She mentioned how the static images just aren't appropriate for our assessment today for soft tissue management, and what we should be doing is a video assessment. I know David Sarver has also spoken of this previously, but the idea of looking at the soft tissues in animation, the incisal show, rest, smiling, allows us to build a far more accurate picture of where we should be moving these tissues to. She spoke about the cone beam CT and what it facilitates for her in her management of orthognathic cases. And really one thing we don't get from plain views or 2D images is the relationship of the maxilla to the cranial base. It's challenging to view this image, and we can do it really easily with a cone beam CT. Details of a cant can be quantified. Also, we can start to see other information. The apex of the roots are visible. We can plan the surgical cuts away from them. And the use of cutting guides to ensure that we are accurate by the surgeon to make those cuts. What I quite liked about this is how efficient this process is. So a cutting guide is placed, they use screws to hold the cutting guides in, they make their Le Fort 1 osteotomy cut, for example. Then these same holes are also used to then put the plates in situ. Now, because they've got data from a cone beam CT, the bone depth can be measured and the appropriate screw size is therefore selected. And it's always placed, therefore, in good bone, and they know it's going to stay. She spoke about the advantages of this as an entirety, how there's more accuracy now with a diagnosis using a cone beam CT. There's greater execution accuracy due to the surgical guides that are present. There's greater safety, they can identify the nerve, but also allows far better assessment of our delivered treatment, and we can modify accordingly through learning as a process. And there are downsides to this as a technique. The cost, it costs between £2,000 and £3,000 per patient. The soft tissue analysis is still unpredictable, and this is still, I feel, the panacea of orthodontic and orthognathic management. What actually happens to the tissues? Can we predict it? Airway analysis is also unpredictable, and it does take time to do this planning. It can take 60 minutes per patient to plan these cases. However, this is not clinical time or surgical time, which is far more costly. So there is still an advantage there in the clinical saving, both surgically and orthodontically. Now then she went on to describe airway considerations, how when the mandible is set back, there can be a significant change to the airway space. She spoke about how planning around obstructive sleep apnea looks more towards biomaxillary advancement, and how we should be carrying out some rudimentary assessments for our patients. The Mallampati is a really easy method to use, essentially a visual assessment for the back of the throat. She described that OSA patients generally have a score of 4, which is obstruction usually due to the base of the tongue. She then went on to body dysmorphia. She described how it's prevalent within the population around 1.7 to 2.4%. However, these patients are usually seeking treatment because of their condition of body dysmorphia. She explored COVID and the pandemic that we are still living through, and she described how in a paper by Cricket in 2020, this concept of Zoom dysmorphia was described. How by people living in isolation have a greater awareness of their appearance, and it's making body dysmorphia greater within the population as a consequence. She spoke about screening for body dysmorphia for orthognathic patients. There was a questionnaire which is accessible, which we can use, but essentially we're looking at patients preoccupied by their appearance, have a significant distress level, and have some level of social impairment. What Lucy's learned from managing body dysmorphia patients? Well, to have the difficult conversation earlier on. Be aware of patients who've had multiple surgeries in relation to their concerns. And also not to fall into the tendency to offer less invasive treatment. We're concerned about your dysmorphia, let's not do orthognathic surgery, let's carry out orthodontics only. Because fundamentally, these patients who have body dysmorphia are going to be unhappy with their treatment. And we're delaying what is the root cause, which is their dysmorphia and its management. This next lecture was the Northcroft 2021 winner. This was Johnathan Sandler, and the lecture was entitled All the Roads We Have Are Walking Are Winding. This was Jonathan's look back at the research he had been involved with, which was 6 key aspects of the orthodontic literature. His journey started looking at magnets for impacted teeth. This was his paper from 1989 and 1991. And it was interesting how this came about. It was a discussion with a colleague, Johnathan Sandler, and then they started carrying out investigations and applying it to clinical practice. He was also involved with a landmark study looking at functional appliances with Kevin O'Brien in 2003. And his look at this study was to investigate the claims of early treatment versus delayed treatment. However, this study also looked at the psychosocial aspect of it, which for the time actually was a relatively new concept. And actually it reduced the risk of trauma, but also improved self-esteem. So for those patients, early treatment is indicated. This was one that won the Dual Award in 2008 with the American Association of Orthodontics. His other research looked at the use of archwire sequences. That was by Nikki Mandel in 2006. It looked at a range of different archwire sequences and essentially showed using an 016 nickel titanium wire, 1825 nickel titanium wire, moving on to 1925 stainless steel is the most efficient. But what was interesting is that I think archwire choices tend to be quite an emotive subject. And what they found from the study is that there was no difference in discomfort or root resorption present. So perhaps we shouldn't be so forthright when it comes to choosing the morally correct archwire sequence. He also looked at photography, and this was a study by Mandel in 2002, to look at the reliability of photographs sent in and to see if they could be used as a screening tool, and he found that was true. Interestingly, the quality of photography varied depending on the clinician. Compared to a professional medical photographer, a nurse, and an orthodontist, the extraoral photos were the same no matter what, but the intraoral photos were far better quality for the orthodontist taking them. Next, Johnathan had conducted some randomized controlled trials. The first was looking at implants, a mid-palatal implant versus headgear in 2007. This was by Benson as the first author. They looked at maximum anchorage cases and showed there was no difference when patients wore the headgear compared to implant, and they were able to maintain absolute anchorage. Then the final study that Jonathan's been involved with is the randomized controlled trial, which led to his PhD in 2014. And this study won the Turpin Award with the AJODO in 2015. So it was a very well-conducted study. And he looked at the use of a temporary anchorage device versus a Nance TPA versus headgear in absolute anchorage cases. Overall, well, there was no difference when it came to the rate of tooth movement. However, when it came to looking at the occlusal outcomes, the PAR scores were better in cases with temporary anchorage devices. When it came to patients' preferences, they preferred the use of either a Nance or a TAD. However, headgear was the least popular. Discomfort levels, again, were higher when it came to use of headgear and lower with TADs and a Nance. It was interesting to hear Jonathan's reflections on his own research and how they genuinely came from a clinical question which led on to the research. And it was great to see his contributions to the field, summarized, and his opinions and thoughts on the process. And that brings us to the end of day 2 of the British Orthodontic Conference. So the key take-home messages, well, when it comes to managing trauma with patients in orthodontics, there's a really, really succinct website out there, www.dentaltraumaguide.org, and this is made by the International Association of Dental Traumology. They've got all the best evidence, really easy photos and flow diagrams to tell you what to do, and also the prognosis. I think that's a really valuable tool to have. Next, in managing canines, trying less herodontics. Just because it's impacted doesn't mean you have to align it. And to consider the use of Paeds, but only specific requirements, and looking at just the distal or mesial vectors. Orthognathic surgery, to have an awareness of body dysmorphia and to explore it with patients. And also looking at obstructive sleep apnea. The Mallampati scores, really simple to do and gets you a quick eye as to whether or not this is an issue which is going on. Hope you guys have enjoyed listening to day 2. Please do subscribe and look forward to day 3 coming out soon.